Hi, everyone. Thank you so much for being here today. We have the esteemed privilege of having Dr. Scott Levenson here. He is an esteemed gastroenterologist in the Bay Area, and he's here today to talk about a focus on abdominal bloating, exocrine pancreatic insufficiency, and cancer screening. So Dr. Scott Levenson founded the Digestive Care Medical Center in 2003, which emphasizes prevention, diagnosis, and treatment of digestive disorders and liver diseases. He completed his fellowship in gastroenterology and hepatology at the University of California, San Francisco, UCSF, and board certified in gastroenterology. He has been practicing in the Bay Area for more than 3 decades. So thank you so much for being here today. It's a pleasure.
Thank you, Dr. Chen.
Thank you.
I'm gonna grab the, when I think of you, Dr. Chen, I think of all the patients you sent me with abdominal bloating over the years. And you made me the specialist in that area because you delved into finding out what the cause was and didn't give up. And a lot of times we find the cause and it makes a big difference in patients' lives. So we're going to focus on abdominal bloating and then focusing more on exocrine pancreatic insufficiency as one of the more common or less recognized causes at times of bloating. And then since we're at human longevity, of course, we have to at least address screening in gastroenterology. So I am in private practice about 20 minutes south of San Francisco, and I see all kinds of patients with these symptoms. So when you talk about abdominal bloating and gas, patients will say belching, they'll be bloated, they'll be passing gas, and it all relates to, is there too much intake of gas or is there too much production? And when we look at intake, of course, carbonated beverages, that's without saying. There's aerophagia where patients are swallowing air, and that'll happen if they're chewing gum, using hard candy. And then for our sleep apnea patients that are on CPAP, of course, it's positive pressure, so not all the air goes into their lungs, but a lot of it will go into their stomach. And inevitably, the sleep doctor, pulmonary doctors aren't aware of that. Patients will come to me, they're belching, they're bloating. And one of the things that can be done is, in conjunction with the sleep doctor, is decreasing the pressure of the CPAP. And sometimes that can make a big difference. And they don't always make the connection of the CPAP to the abdominal bloating and belching. And then we see it, of course, in vegetarians, vegan, with the cruciferous vegetables, broccoli, cauliflower, there's going to be production of gas. And when we talk about gas being produced in the intestine, we're usually talking about hydrogen, methane, and hydrogen sulfide. All right, and when that is being produced, it's being fermented by the bacteria in a small bowel. So some of the more common causes, of course, lactose. So most of the world, of course, is lactose intolerant. It's meant to be able to digest mother's milk. Some Northern Europeans retain it, but the majority of the world is lactose intolerant. When you go to fructose and sucrose, those are less common. Sucrose is about 1% to 2% of the population. Under-recognized, it's more tested for in pediatrics. We can test for it when we do an upper endoscopy and actually take biopsies of the small bowel and measure the sucrase and lactase levels, or non-invasively do breath testing. So these breath tests can pick that up. Basically, you do a baseline breath sample, you take the substrate, say it be lactose, and then collect timed breath samples looking at the production of hydrogen or methane, sometimes sulfide. Celiac disease, so that would be in conjunction with gluten intolerance. And those are separate. So gluten intolerance is intolerance to gluten. Celiac disease, more genetic basis, and where the small bowel actually flattens out in the villi. Of course, both will be treated with avoidance of gluten-containing foods. SIBO is becoming more recognized. So SIBO is small intestinal bacterial overgrowth. So in this case, there's too much bacteria in the small bowel. That's causing fermentation, and that can be tested with a breath test and treated when it's found. And then we're going to delve into exocrine pancreatic insufficiency, basically a deficiency in pancreatic enzymes. So that will lead to maldigestion. And then we see it sometimes in postoperative where the plumbing's been rearranged, gastric surgery, pancreatic surgery, bypass surgeries. So a little anatomy and physiology. So when we eat, food starts to get digested with the salivary amylase. goes down the esophagus in the stomach. You've got the acidity of the stomach to hydrolyze protein, mechanically breaks up the food, and then it's coming into the duodenum where most of the digestion and the rest of the small bowel takes place. And then it slowly goes into the colon where the colon absorbs water, forms stool. So the lactase, sucrase, those enzymes are in the lining of the small bowel. The rest of the enzymes are coming from the pancreas. And the pancreas has two functions. Of course, the endocrine function, so it's producing hormones, insulin and glucagon to regulate, say, glucose. But about 85% of the pancreas is devoted to exocrine function. So producing the enzymes that are going to break down food. The three basic food groups: amylase breaking down carbohydrates, proteases breaking down proteins, and lipases breaking down fats. Interestingly enough, the amount of enzymes, say lipase, 500,000 to 1 million units per meal. And we really don't get deficiency until you're about 1/10 of that. So there's an overabundance of enzymes. And so really when we're looking at EPI, a good portion of the pancreas is not functioning. And that leads to maldigestion and some of these other symptoms that we'll talk about. The other thing the pancreas produces is sodium and bicarbonate. So in response to acid and food coming into the intestine, it secretes that to buffer it and help with absorption. And of course, you have bile coming from the liver for fat absorption as well. And unfortunately, a lot of patients won't be recognized for a long time just because they're not looking for this condition. And if we look at how common is it, so it varies, of course, depending on what the underlying etiology is. So for chronic pancreatitis, you'll see that it's about 25–30% of patients with chronic pancreatitis. That's usually alcoholic pancreatitis, idiopathic pancreatitis. We see some autoimmune pancreatitis. Not every chronic pancreatitis will be void of enzymes, but about 30% will. Type 2 diabetes, just because it's such a common condition, of course, that makes up a big chunk, about 15–20% of those patients will have it. Type 1, cystic fibrosis, one of the hallmarks, of course, is pancreatic insufficiency along with the lungs. So that's a high incidence there. And then pancreatic cancer, actually just a minority of patients with pancreatic cancer. But anything that will obstruct the pancreatic duct, as you can see, could interfere with the enzyme release. So due to lack of awareness, it can take 3.7 years to make a diagnosis sometimes. Okay. So what are the symptoms that these patients have? Well, again, they're not digesting. These are non-specific symptoms sort of on the left, where there's nausea, there's passing rectal gas, there's bloating, there's the pain. Very non-specific. That could represent a lot of different etiologies. But once you get that maldigestion and you have the weight loss, one of the hallmarks is the steatorrhea, so fat in the stool, smelly, the stools are floating. You even may see oil in the stool, in the toilet bowl. And then along with muscle wasting, vitamin deficiency, particularly the fat-soluble vitamins A, D, E, and K, and some electrolyte deficiency. So some of these patients will have ongoing weight loss, maldigestion, low vitamin D, and we're distinguishing that from these other conditions. So in the GI world, Crohn's disease, celiac disease, irritable bowel with diarrhea predominantly, those can all have that same bloating, gas, diarrhea, not usually the weight loss other than, say, Crohn's disease, and then cystic fibrosis. And when they did a survey of patients with chronic GI issues, 25% of the patients with EPI were originally diagnosed with another GI condition, and subsequently EPI was found. A majority of the patients had never even heard of EPI, and 78% of the patients weren't aware that the GI symptoms could be EPI related. So it was under-recognized, and I think it's becoming more recognized, but it's one of those conditions. It's really rewarding when we find it because it's so treatable. Well, how do we test for pancreatic function? Well, once upon a time, the most objective way was to put a tube down into the intestine, nasogastric, nasointestinal, measure how much bicarbonate and secretions are coming from the pancreas. Obviously, that's not practical. So the next step was to do a 72-hour fecal fat. What's that? Well, we would give the patients a 5-gallon paint can take it around with you for 3 days and bring it back to the lab. Well, patients didn't like it, the lab didn't like it. It was easy to order, but it evolved into the fecal elastase. So that's a human pancreatic enzyme, meaning that it won't be affected if someone's on pancreatic enzyme replacement. You can still measure it. And so a level under 200 is low, under 100 for sure is quite low, and that can be diagnostic. So that's used fairly frequently. I often also will just sometimes practically give patients pancreatic enzymes to see if it will help, because you'll know within 2 or 3 days if it's going to make a difference. There is a tendency when giving pancreatic enzymes to sometimes underdose. So if a patient doesn't fully respond, sometimes it just means they're being underdosed. Okay, so what are some treatments? Getting to treatments. Quite a few treatments available for bloating. You're thinking of how you're going to mitigate this gas. Well, one way would be to try to find the offending food and correlate it. The problem with that, and we have patients do food symptom diaries, it may take 5-7 days after a certain food for the symptoms. And it's very hard to get a controlled study on that with patients. So that's not really practical. So it kind of evolved to doing this low FODMAP diet. So restricting particularly lactose and gluten, some of the alcohol sugars, minimizing the gas production. And then doing that for a couple of weeks. It's hard to stay on that for any period of time because it's so restrictive. The compliance won't be very good. So then you add in some of these 7 basic food groups. And usually start with the one that you think is going to be the offending agent, so you don't put someone through 2-3 months of this. But if you don't, then you add, and you have to add it about once a week. You can't just add it in a day or two, because again, symptoms can take a while relative to when that food was ingested. And then, of course, the anti-gas preparations. Then you go to the pharmacy, you'll see zillions of these on the shelves. Simethicone is what's in Gas-X, Phazine, Mylicon. It basically breaks up the bubbles. We use it sometimes with a scope to break up bubbles to get better visualization. Beano is an alpha-galactosidase that breaks up the polysaccharides and oligosaccharides to make that easier to digest. And then one thing that I found pretty helpful is activated charcoal, or charcoal caps is one of the brands, just as absorbing. It tends to be a little more effective in my experience than, say, the Gas-X and the Phazine. But those can be used, but of course they're temporary. And then, of course, if you knew there was lactose intolerance, then you're going to either avoid lactose-containing foods or supplement with lactate. So again, those enzymes have to be taken at the time of ingestion of lactose. So lactate is over the counter. Sucrade would be for sucrose intolerance, sucrase deficiency. That one is a prescription. And so there usually needs to be, for the insurance, some objective evidence of the deficiency, either by breath test, or more definitive is when we do a small bowel biopsy and measure the level. And PERD is for pancreatic enzyme replacement therapy. So of course, that's going to be the treatment for EPI. And again, several manufacturers of that, very safe to take. And we tend to make sure it's weight-based dosing, so making sure that patients get enough of it. And it's got to be taken right with the food, so it's getting down to the small bowel and digesting at the same time. And then, of course, antibiotics, and this is geared a little bit more towards SIBO, small intestinal bacterial overgrowth. So Xifaxan or rifaximin, that's that non-absorbable antibiotic. So it's got a number of indications. One's traveler's diarrhea. We use it for hepatic encephalopathy. It's got some activity against C. diff. But in this case, its FDA indication is for irritable bowel diarrhea, although it is used for SIBO off-label. So it's typically 550 milligrams. You take it 3 times a day for 2 weeks. And if it's methane SIBO, then we'll usually add an anaerobic antibiotic to it, like neomycin or metronidazole. Prior to rifaximin, often used either metronidazole by itself, amoxicillin, clavulanic acid, or augmentin, tetracycline, Vectrum, these broad spectrum antibiotics that would take care of aerobic and anaerobic bacteria. So in terms of rifaximin, it works about 70% of the time. say for SIBO. The problem, and the thought with SIBO is the bacteria from the colon, which has trillions of bacteria, migrate up into the small bowel, which should be relatively sterile. As you eradicate that, that can recur, and about 50% of those patients recur. You can treat up to 3 more times. But because it's targeted, it won't give yeast infections, won't affect the rest of the flora. The Pepto-Bismol or bismuth subsalicylate is more antibacterial as well. Patients sometimes will get relief with that. Probiotics, not a lot of evidence for that. Commonly used, very safe. So I typically have patients do that. They're usually doing it on their own anyway, and sometimes it can be helpful. All right, so it's interesting, and this may be hard to read, but if you look at high FODMAP foods versus low FODMAP in the various categories, so you say for vegetables, high FODMAPs, artichokes, asparagus, cauliflower, mushrooms, whereas the low ones, low FODMAP vegetables would be eggplant, green beans, bell peppers, carrots. For fruits, high is apples, apple juice, cherries. Low, cantaloupe, the melons, a pineapple. Dairy, of course, lactose-containing foods. And then low FODMAP dairy would be the non-lactose, like almond milk. Proteins, high FODMAP would be legumes, poultry, seafood. Low FODMAP proteins would be eggs, tofu, things like that. So you can see, like nuts, high is cashew, pistachios, low is macadamia, peanuts. It can be complicated, and it's something that a dietitian can be very helpful in navigating that with the patient. Okay, so from that, and we can take questions at the end, we're going to completely shift into screening. Since we are at human longevity, where are we at with screening and gastroenterology in 2023? And this is an evolving field given new testing that's coming onto the market. Just in general for cancer, and this is cancer incidences, so men on the left, women on the right, and this isn't mortality, it's just incidences of it. So of course, prostate's the most common cancer in men, and this is over the last 40 plus years. And as screening was being used more, of course, found more cancers, and that's still pretty high. What's encouraging is that lung and colorectal for men is that the incidence is going down. So despite increasing screening, we're seeing less. And we'll go into why that is, and has to do with sort of being proactive and catching things at an earlier stage, say in colon cancer as polyps, removing those polyps and helping to prevent the formation of colon cancer. Women, still colon cancer going down, lung had gone up and then it's coming down. Urinary, bladder, uterine cancer, pretty level. Melanomas in both men and women going up, thyroid, liver slightly going up too. So what's encouraging is that colon, both men and women were making strides there. And if we break down now mortality, so deaths from colon cancer by age group. So the top line is our patients 75 to 84. So they have, of course, have the highest mortality. But what's encouraging is that that's almost gone down by 50% from 1999 to 2019. So over that 20-year period, again, the mortality has gone down. Not quite as good an improvement, starting at a lower level for 65 to 74, which is the second line. The third line down would be 55 to 64. It's a little more level. And what's a little discouraging is that the 45 to 54-year-old line is fairly level. And why is that? Well, screening adherence rates are higher as we're older, based on our mortality maybe, but we're at 65% or so. 45 to 50-year-olds are barely at 50%. So it really is a difference based on ages as far as patients coming in for screening. And as you know, the age of screening was decreased 2 years ago from 50 to 45 for colon cancer, and yet getting those patients in has been a little bit of a challenge. And when we look at what are best screening tests, so colon cancers all start out as polyps. Less than 1% of polyps go on to colon cancer, but there's a progression. So polyp forms, what forms a polyp? It's thought to be the toxins in the colon irritating the wall. The cells start to divide. At age 50, 35% of men will have at least one precancerous, we call an adenomatous polyp. Women, it's about 25%. And some of those polyps can progress, increase in size, change morphology, and become more at risk for turning into a cancer where that dotted line is. Well, if you think about screening, when you're looking for blood in the stool, you're looking at fecal DNA, you're sort of looking at the right side of the screen where the cancer is already developed. When we're doing colonoscopies, we're focusing here, getting people at polyps, removing them, and cutting down that progression, and hence giving that mortality curve a negative slope. So that being said, what do we have? So average risk, so no family history, no symptoms, no previous colonoscopy, start at age 45, whichever screening modality. And it's generally felt that whatever is going to be the most adherent, whatever the patient's going to be most adherent to is the best screening. So doing something is better than, of course, doing nothing. So I'm making a case that doing colonoscopy, it's normal every 10 years. Cologuard, so that's, a Cologuard is measuring the human globin. So it's a FIT, it checks the stool for human globin, and it's also checking fecal DNA. And when it gets reported, they don't tell you what's positive, what's not. It's kind of an algorithm. They don't know. So you don't know exactly. But it's got to be repeated every 3 years. And the company that makes it is very, I mean, they send faxes every 3 years to make sure your patient hasn't gotten it done. So they're very on top of it. I'm not a big fan of the test, but they are promoting it quite heavily. The FIT would be just the stool for the human globin. So this FIT kind of replaced the stool guaiacs that we used to do. We had to avoid red meat, vitamin C. This is a human globin. You don't have to do any of that. And it's just a one test, not three. And studies have shown that helped with decreasing mortality from colon cancer, in large part because when it was positive, those patients had colonoscopies. Sigmoidoscopy also showed benefit, but now we rarely do that because it is, again, only looking at a third of the colon, and you have to combine that with stool testing. Virtual colonoscopy, that seemed encouraging when it came out because kind of non-invasive. The problems were that you still had to do a bowel preparation, a fair amount of radiation. If you found something, you then had to go to a colonoscopy. And when it was done on the same day, that was great, but scheduling makes that difficult. So oftentimes patients come back. There have been even reported perforations with the virtual colonoscopy because they're putting a balloon in the rectum, inflating. They were trying to tag stool so you didn't have to do the bowel prep, but it really hasn't been used much except in someone that can't, say, undergo a colonoscopy for other reasons. Then came along colon capsule endoscopy. So this is a little digital camera that you swallow. It's been out for a long time for the small bowel. We do it all the time. It works pretty well. In the small bowel, you've got a small diameter. Once it enters, it's forward or backward, it sort of stays oriented, and it gets through there in 4 to 6 hours. The colon, you have to do a really good colon prep. It's going to bounce around a lot. It's, again, just diagnostic. It's not great. And then came blood-based. So these are looking at the DNA in the blood. Several companies have come out with that. Question how often you would need to do that. And we'll look at some of the sensitivities and specificities with those. Where's the largest benefit in screening? It's in the 45 to 75 years range. When you get to 76 to 85, we tend to individualize that. So depending on the patient's overall health and previous, essentially if they've already had a colonoscopy, those results. And then we continue until life expectancy is less than 10 years. So I guess here everyone's 100 plus, so we will do this till 90 plus. All right, now that changes when it's high risk. So high risk would be family history. Often that's before the age of 60, but I say if someone had colon cancer at 70, they might have had it at 55. So first degree relative, you've had previous colon cancer, of course, or if you had polyps before. If you have an underlying inflammatory condition, ulcerative colitis, Crohn's disease of the colon, that inflammation can lead to changes over time. They need to be screened more aggressively. And usually we start at earlier ages, at age 40 or even younger, 10 to 15 years, because it's thought to take about 10 years to go from a polyp to a colon cancer, 10 to 15 years. So you want to be ahead of the curve there. And I think I've shown you already that colonoscopy does help prevent it by picking it up early. And then when it's high risk, typically we're repeating it 1 to 5 years, depending on how many polyps they have. What are the risk factors? So I have a number of patients with Lynch syndrome. So they've got the mutation, very high risk. You start checking them at 20 to 25, and we start doing the colonoscopies every year, the upper endoscopies every couple of years. The women get hysterectomies after childbearing. Those patients that are really high risk, very aggressive, because they form these aggressive tumors. So some of that gets individualized. So when you look at sensitivities and specificities, this is mostly sensitivity, actually. And the FDA now has said the sensitivity has got to be above 74% for a test to be approved. So FIT, just barely makes it there. The problem with the FIT, and that's the stool test, is that it's not picking up. So advanced adenomas would be these precancerous polyps. Advanced serrated lesion, these are these very flat right colon lesions that kind of blend in. They're very hard to find. And those are a little bit more worrisome. So it's not very good at picking those up. And again, it's picking up when the cancer has outgrown its blood supply, it's ulcerated and it's shedding blood, or DNA in the case of the Cologuard, which would be the second one, the FIT fecal DNA. So that has a sensitivity of 92%. It has a false negative rate of 8%, false positive rate of 13%. I think those numbers are actually worse than that. I just had a 54-year-old today, had a negative Cologuard last year, had some changes in bowel habits. His primary sent the patient back, colonoscopy, had a rectal cancer, pretty large rectal cancer. So 54, negative Cologuard a year ago. And I haven't been that impressed. And on the flip side, we see patients getting these positive Cologuards and then we find nothing. And then do we need to look further? Do we need to look at the upper intestine? It's not, in my mind, not a great test. It's getting improved, but it hasn't yet. So colonoscopy, of course, is very good at picking up almost essentially all the cancers. As you can see in that third column with these right colon, it can miss 10 to 15%. We like to think we're perfect, we're not. So it is recommended when you're having colonoscopy that we look twice, 3 times, more effort on that right colon. Various techniques to pick out those polyps that tend to blend in. CT colonography, again, as well as capsule colonoscopy, very good for colon cancer, not so good on these serrated lesions, pretty good on the advanced adenomas. So again, when you look at these tests, colonoscopy is really the only one that's making that effect early on in the scheme of things to prevent the colon cancer. Okay, so I'm going to just briefly talk about the rest of the GI tract. So upper GI screening, what do I mean by that? So chronic GERD, common problem. Someone has reflux symptoms 5 years or so or more, probably deserves an endoscopy at one point in their life. And why is that? Well, if you have chronic acid irritation of the esophagus, you can lead, in about 10% of the cases, to Barrett's esophagus, where the lining of the esophagus changes cell type and puts people at higher risk, 20-fold risk of esophageal cancer. And when we find that, then those patients get endoscopies every 3 to 5 years. And I found patients where that has picked up cancer early on. So again, when you find those people at high risk, if it's normal, we call it NERD, non-erosive reflux disease. They probably don't need repeat endoscopies unless they're having some other issues. Gastric cancer. So in the Far East, very aggressive screening there. And if there's family history, heavy alcohol, tobacco use, those are all risk factors. And of course, checking for H. pylori, the stomach bacteria. And I'm amazed still that people don't, or at least the lay public, a lot of people don't remember the story of H. pylori back in the 80s when Barry Marshall and Robin Warren were looking under the microscope, they're pathologists, and they saw bacteria in the stomach and associated that with stomach problems and later stomach cancer. No one believed them, and they poo-pooed him. He infected himself, he treated himself, And then 2005, 20 some years later, gets the Nobel Prize. They get the Nobel Prize in medicine for discovering this because everyone thought ulcers were stress, aspirin, Advil. And this bacteria, the H. pylori, is a World Health Organization class 1 carcinogen. So I do put the caveat when we find it, we usually treat it. And treatment's better before it develops precancerous changes. Precancerous changes are where the stomach changes cell type. Because if you treat it after that, they still at pretty high risk or some risk for progressing to stomach cancer. But they will get often more reflux because the bacteria lives by buffering acid. And so they may get more reflux. Anyway, so H. pylori, very common in other countries, maybe 15% in the US. Pancreatic cancer. I think we're all fearful of pancreatic cancer because it's so hard to screen for. It's such a rapid cancer. And so certainly when there's a high risk, what's high risk? Well, patients have chronic pancreatitis, if they have a family history, smoking, drinking, potentially diabetes, they consider screening. Obviously, you guys are looking at the genome, genetic mutations have been associated. There's some blood-based screening. CT screening, that's difficult because again of the radiation, how often are you going to have to do that? You can do that for lung cancer with low dose CTs. It's how much higher dose in the abdomen. MRIs, and I think off the screen is endoscopic ultrasound, but that becomes not that available on a routine basis. So it's still one of those cancers that is pretty hard for us to pick up early. And then the last bit I have is on liver cancer. And this would be primary liver cancer, not cancer from somewhere else spreading to the liver. So risk factor there, again, chronic inflammation. The big one worldwide is hepatitis B. So chronic active hepatitis B, high risk for liver cancer. Once the liver is scarred for whatever reason, whether that's alcohol, viral hepatitis, we're seeing more and more this non-alcoholic fatty liver disease. So risk factors, obesity, diabetes, hyperlipidemia. And some of those patients, used to think that was a benign condition, but some of those patients do go on to cirrhosis. And we don't have a lot of way to intervene medically yet. Hemochromatosis, again, where there's iron deposition in the liver, high risk for liver cancer. And how do we screen? Typically, every 6 months, abdominal ultrasound, an alpha fetoprotein, it's a blood test, and then sometimes periodic MRIs or CTs, again, where you can pick up these liver cancers at an early enough stage that they may be resectable or be transplant candidates. But again, it can be difficult to pick those up early too. Okay, so that's all I had prepared. I just wanted to focus on the bloating, focusing EPI, quick run through screening. I'm happy to answer any questions related to this or anything GI that you want to throw at me.
Questions. A lot of clients, as you know, share with the pancreatic insufficiency, and they do ask me if they go on enzymes, do they then have to take it forever, or is there a way that they can get off of it? What's your experience been with that?
Correct. Patients don't want to be on a medicine forever.
Right. Yeah.
And I usually don't commit them to being on it forever, but their adherence is pretty good when it relieves their symptoms.
Right.
So I usually say, well, let's give it 2-3 months, get the symptoms under control, and then try stopping. And they usually will try stopping on their own. And maybe half the time they can stay off of them for whatever reason, whether the pancreas regenerates somewhat or they're just not symptomatic. Maybe the other half of the time they end up back on it. So I don't commit them long-term to the pancreatic enzymes. But
Is your experience that they'll usually stay on it? They'll have to stay on it long-term, or would you say it's like 50-50?
I would say it's about 50-50.
Okay. And, you know, a lot of my clients will ask, like, if they're not a diabetic, they don't have cancer, obviously, because our MRI can pick up stage 0 pancreatic cancers. They don't have cystic fibrosis. They don't have chronic pancreatitis. Like, what are some of the more obscure reasons that they may have a EPI?
Well, okay. So if it was autoimmune pancreatitis,
Yeah.
so women, men also can get it.
Yeah.
You can do blood tests for that. If they've had the previous surgeries, we see it a lot of times, and probably the biggest category is idiopathic. We don't know
Right.
for
Yeah.
whatever reason. People see that, they're diagnosed with EPI, and the first thing that goes to the head, of course, is this pancreatic cancer.
Right. Yeah.
So often we are imaging the pancreas. You're doing it ahead of time. We may be doing it after that just to
Mhm.
reassure them. And most of the
Right.
times it's not
Right.
pancreatic cancer, but it could
Okay.
be.
I've seen quite a bit with SIBO. Have you noticed that some clients with like SIBO might actually have dysfunction for enzymatic activity in the gut?
Yeah, and it all brings up like secondary SIBO. So
Yeah.
if you're not in the as you saw in the duodenum, if you're not digesting there,
Right. Right.
whether it's lactose intolerance, sucrose intolerance,
Yeah.
or EPI,
Yeah.
then you're basically feeding the bacteria in the small bowel, and you're contributing to this sort of secondary
Yeah.
SIBO. And you may end up having to treat both,
Right.
or you treat the EPI and the SIBO may get better
Okay.
that way too.
Okay.
You know, exactly. It's a good
Yeah.
point. And how did you find all these patients with bloating? Or they find you?
No, they
Because-
find me.
Yeah, you became the expert. I mean,
Yeah,
really
so
good.
I saw a lot of clients through integrative medicine care.
Okay.
And so they would come in with gut issues that no one else can figure out. So then I would go down the road of looking for EPI or SIBO or something else that someone hasn't looked at. Like I picked up like early inflammatory bowel disease that people haven't looked into. Just really being cognizant of watching the client and not blowing them off early on, right? I think that's one of the biggest thing is if they're not severe enough, sometimes unfortunately conventional medicine just kind of blows them off. So it's always nice working with doctors like yourself where you're open to really looking at clients early on. And so we're finding a lot of these clients where, like you said, a lot of EPI is not diagnosed for like 3 to 4 years because they're just not being looked at for EPI,
Right.
or that no one's bothering because it's like, oh, it's not that bad, quote unquote, but it's there and it's
Right.
bothersome.
And it's
Yeah.
so easy to diagnose.
Yeah.
Like sucrase deficiency, a little more difficult to diagnose. When we do endoscopy for bloating or whatever, we
Yeah.
take, it doesn't cost the patient anything extra. We take biopsies for lactase and sucrase, and we give them levels, and we pick up the 1 to 2%.
Yeah.
And you say, well, why isn't every GI doctor doing that? Well, you need a freezer. And they
Right.
don't have a freezer in their unit, so they don't, and they're not getting, incentive to do that, so they're not
Right.
testing for it. But you, like you say, you have to test for it to find it.
Right, exactly. Yeah, willing to
Yeah.
kind of go down that route, right? Yeah. And then another question I have for you is I do have patients with recurrent H. pylori where they've had it treated multiple times. Like, what's your trick with that? Or what are your thoughts on it? Is there something that's keeping it recurrent? Or is there a different drug regimen that you choose for them that can really eradicate it once and for all?
Yeah, it's interesting because there hadn't been new treatments for H. pylori for a long time.
Mhm.
So the initial treatment was the Prevpac, a combination of an acid blocker, omeprazole, and clarithromycin. Well, because of all the use of Z-Paks and azithromycin resistance, that now has about a 70% eradication rate.
Mhm.
And so then the better one was a quadruple therapy, which was bismuth, metronidazole, tetracycline, and an acid blocker.
Mhm.
And that's now, because of metronidazole resistance, is down to about 80%.
Mhm.
And so the newer one, it's been out a year or two, is Talicia. So
Mhm.
that's a combination of amoxicillin, rifabutin, and very high doses of omeprazole, and getting the pH very high. And
Okay.
that's up at 90%.
I see.
Now,
Okay.
last year, the new treatment also got approved with vonoprazan. It's a new type of acid blocker,
Uh-huh.
and amoxicillin, and as well as amox. And those, they're not marketing that yet, but it's probably not any better than Talicia. So again, you have to make sure patients aren't penicillin allergic.
Right.
But so I will start now with the most effective, if I can get it, is the
Mhm.
Talicia. And they actually, the company's got a $249 money back guarantee. If it doesn't eradicate it,
Wow.
they
Okay.
refund the patient. So
Wow.
that's how
Okay.
much strongly they believe in it.
So,
But
so you
yeah.
do feel like then it's just rather that instead of it coming back, it's just that it never got eradicated.
Typically,
Is that
it's
what it
never,
is?
it's
Okay.
not that transmissible.
Okay.
I mean, we will start to sometimes, well, now you check family members.
Uh-huh.
If you find them, you're going to treat them at the same time. It's hard to know how far down that road to
Okay.
go. But there's no question, it's becoming more, it's more resistant, just like
see.
C. diff infections,
Uh-huh.
harder to treat, harder to eradicate.
Okay.
So if someone has H. pylori, though, you should probably let your family members know to also get it checked, correct? Okay,
Correct,
great.
yeah.
And then the last question I had was for colonoscopies, what we usually do here is we recommend that they get their colonoscopies, but then we do Cologuard in between to be extra sure that they don't have colon cancer. What are your thoughts on that?
stick with just colonoscopy. Yeah, Cologuard,
Yeah.
I mean, it's a great business model.
Yeah.
And it's just, they're coming out with another generation of, they were going
Yeah.
to use us as a testing site, and they didn't develop it, I think, because they don't have to develop it. Everyone's using this
Yeah.
first generation.
Yeah.
There are some blood tests that are going to be using proteins and fingerprint patterns that will get that up to the 90 to 90+%. So I think you may end up switching to the blood-based
Yeah.
ones that will include the DNA
Yeah.
plus.
Yeah.
They're quite expensive right now, but
Yeah.
they're coming down.
I think for us, we found a couple clients who actually were doing the colonoscopies, but we caught them and they were supposed to do it again 10 years later, but then we caught them in between with the cancer finding. So even though there is that, like, you're positive, what is it really? We did kind of find a few cancer clients that way. So I think being that human longevity is very big on just making sure we catch everybody with cancer so that no one dies from cancer. I think that's where we're going from. But
Yeah. So
I totally hear you.
personally,
Yeah.
I was happy when I had my colonoscopy and had a polyp or two because I got
Yeah.
to do it again in 5 years.
Yeah.
So I think the big, do the
Yeah.
colonoscopy every 5 years, don't wait 10.
Yeah. I think
Because
that-
you can get interval cancers, and either
Exactly.
because it's not a good prep, it
Yeah.
was missed, there's
Yeah.
right colon
Right.
lesions that are very flat. That
Do you see if insurance covers those? If, let's say, the GI doctor didn't find anything and they say in 10 years, if they went at 5 years, does insurance cover though?
only if they wiped and saw a little bit of blood on the toilet tissue or something.
Okay. 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 Yeah.
But no, not for screening. It's interesting, like Medicare covers average risk patients every 10 years for colonoscopy.
Yeah.
High risk, they cover every 2 years. So they have
Right.
one polyp, they'll cover it every
Right.
2 years. Well, we don't do them every 2 years.
Right. Right.
So it's
Okay.
kind of an all-in-one thing. So
Okay.
that's why I was saying, I think 5 years probably
A good one.
colonoscopy is a
Yeah.
good midpoint.
Yeah. I think maybe the takeaway point is don't just do Cologuard. You definitely still need to do colonoscopy.
Right, just
is
like
what
that
it is.
54-year-old today
Yeah.
that had a
Yeah.
negative Cologuard, you feel
Yeah.
reassured.
Yeah. Yeah.
Again,
Yeah.
one of the issues is you do a colonoscopy, when do you do the next fecal test or
Mhm.
Cologuard test?
Mhm.
Because oftentimes patients will go back to their primary doc and they're just regularly doing their physical, they do the rectal, and it's
Mhm.
positive. Well, they just had a colonoscopy 3 months, 6 months ago.
Right.
Do you repeat the colonoscopy? You're put in
Yeah.
this awkward situation.
Right.
So
Mhm.
the experts will say, don't do that for about 5 years after you do a colonoscopy,
Mm.
maybe 3 years.
Interesting.
If you want to
Okay.
be more aggressive, but.
Okay. But depends on the case, obviously.
Right.
Yeah. Yeah. Okay. Perfect.
I'll start with we can alternate between like a live question and a question on that one of the webinar viewers are asking, the
Okay.
attendees. One of them, I don't know if they want me to put their name out there, but this person says, I have EPI and started taking pancreatic enzymes. My levels quickly went from 57 to 166. Can this treatment lead to a normal pancreas?
Yes, so pancreatic function, because you're replacing the enzymes, and some patients will say, what are the, you have to realize you're taking these enzymes and they're not absorbed, so you don't really worry about drug-drug interactions. It's just the enzymes are going down with the food. So you're essentially repleting the enzymes that are low on, and normal in that fecal elastase is 200 or higher. But if you get above 100, oftentimes symptoms will go away. So as long as you're taking the enzymes, then it should be adequate. Again, if it wasn't quite enough, you could increase the enzymes. So they come in a lot of different strengths so that you don't have a big pill burden, because some of them come from 3,000 to 36,000, 40,000 units, and it's weight-based. So I would say if you're still having a few symptoms, your levels are low, you may want to consider increasing the dose a little bit. If you're feeling fine, no need.
Do you feel like sometimes when they're doing the enzyme, it's almost like allowing your pancreas to rest a little bit so that it can recover, or no?
Well, that's the question. Like, yeah, is your pancreas going to stop functioning? Like, you're taking steroids, your adrenal glands are going to stop producing steroids. No, so it won't negatively, it's not going to damage the pancreas by taking the pancreatic enzyme. We have patients that have pancreatic cancer and having pain. Sometimes the enzymes will help there because, again, they probably have some EPI there too. Any questions?
When you mention the overgrowth in the small intestine, is that solely due to undigested food? Or are there other reasons that there's the invasion of the bacteria into the small intestine?
So what are the causes of SIBO, other than what we talked about from the top end and the bottom end. And a lot of it we don't know. So it's theorized that the bacteria are migrating from the colon up, but that's sort of hard to show. Other conditions that would put people at risk for SIBO, sometimes people with rheumatologic disease will have these diverticuli in their small bowel. They can harbor bacteria. So there'll be nidus, just like you can get diverticulitis in the colon, you can actually get that in the small bowel. That's not that common. So I think a lot of it's unknown. There's a lot of secondary SIBO from indigestion, not fully digesting food on the top end, but why some people are prone towards that or not. Some of the risk factors would be if someone's on acid blockers, like proton pump inhibitors. So acid does also, I didn't mention this, but it does kill bacteria entering our system. So when patients are on the PPIs, these strong acid blockers, a couple side effects from that can be pneumonia. So if they aspirate, there'll be a higher bacterial load going into the lungs. Higher incidence of C. diff, this bacteria that you can get in the lower intestine, and the higher incidence of SIBO too. So if someone's on a PPI, you might also think about, if they don't need it, taking them off when you're addressing the SIBO. But anyway, it's so multifactorial, and it's still a lot of it is not known. And the testing is, unfortunately, the testing is not that accurate for it either, the breath testing. So oftentimes we treat it even when the breath test is negative because the treatment's safe.
So here, I'm gonna put a couple of these questions together. Sunaina was asking, what causes changes to the gut that creates a need for low FODMAP or gas elimination diet? And another question would be, do fermented foods help with bloating? And do they help with digestion?
Okay, so the first one, well, I'll take the second one. So the fermented foods, that's kind of a new fad now too. And sauerkraut and types of things that are being used, and that has been helpful for some patients. I kind of leave that up to the dietitian because I don't want to delve into all the nitty gritty on that. And the other one was about the.
It was regarding the changes to the gut. What causes changes to the gut that creates a low FODMAP?
Changes to the gut. Well, so, and again, a lot of times we don't know that. Even doing all this testing, we still may not find out the cause of the gas and the bloating. And so we're just treating the symptoms, and we're just removing the foods that are going to produce a lot of gas, while we're still trying to identify if there's specific foods for that patient that might be removed from the diet or changed. And again, that's mostly done through dietitian, because it is a pretty arduous process to make those changes and be following that. But the goal there is to remove whatever may be producing the gas. If you're only on a low FODMAP diet while you're kind of evaluating this, because again, it's not very tenable to stay on it, and it's not going to be missing some of the nutrition that you need.
They also come up with if they're on high FODMAP foods, just other things that emit more gas, bacteria in the flora. But also like fermentation, I don't know if you're experienced, but like for the ones that are significant SIBO types, the fermentation foods are really uncomfortable for them because they're already overgrown. But the ones where they're mild on the SIBO, the fermented foods help. So if someone's eating fermented foods and they're first, that's probably an indication that they should get this SIBO test done.
Agree.
Any questions? More on this here. This person was asking, how can I get a prescription for pancreatic enzymes?
So that's a good question. So there's over-the-counter enzymes, but they're nowhere near the strength of the prescription strength. So I don't even use those. Some patients will try that on their own, but just through their primary doctor. But again, a lot of primary doctors may not be aware of that. But if you bring up the condition, well, hey, I want to be tried on pancreatic enzymes, or I want a fecal elastase to check for it, they should be able to get that through their primary doctor. Or you come to the GI doctor. Yeah, you can come.
This person's asking, if my pancreatic enzyme levels are improving on enzymes, do I need to further diagnostics?
So that's kind of a difficult question. So they presumably have EPI The enzyme, the levels are improving with replacement. And then the question is, do you need to do any more investigative testing? And so, again, I said pancreatic cancer is not a common cause, but if there was some indication, then there might be some imaging of the pancreas to be done. A lot of patients will get that. An abdominal ultrasound isn't, if someone's thin, they can often see the pancreas, but they often end up having an MRI or CT, or I guess here they're getting checked anyway. So that would be the only thing. And so I don't want to say they don't need anything. If someone's young and they're doing well, they may not need anything, but it's really an individual type thing about whether they need more testing.
Right, look for the root cause, right? If there is,
If there is one. Yeah, and most of the time, we don't know the cause.
And do you worry if the dog has H. pylori?
Yeah, so cats and dogs can have H. pylori. Don't kiss your dog, don't kiss your cat. Now, there hasn't really been transmission from animals. I mean, it's possible, I'm sure, but yeah, don't worry about it. How did they test the dog? Either did a stool test or a breath test, or yeah, they didn't get scoped, did they? Actually, yeah.
Okay, moving on then. Is there any credible research showing that EPI can be genetic?
Can EPI be genetically caused? There's so many causes of EPI. So, of course, pancreatic cancer can be a genetic basis. Most of the times there's not, but there can be. So EPI, because it's, I won't say a garbage bag, but there's just so many different causes for it that most of the times no. But of course, diabetes, can be a genetic basis for that. If that's the cause of EPI, then yes. So, right, cystic fibrosis. Celiac disease is a little higher incidence of EPI. So there are conditions that are genetically based, but as a whole, it's too diverse a group to say it's just for everything.
And are you aware of any research being done on whether EPI can be caused by COVID vaccinations?
I think COVID vaccination, not the infection.
Vaccinations.
No, but I think COVID and COVID vaccinations, they say, can cause anything. So I don't know. Get the vaccination.
Okay.
Again, those things there's so many variables. How do you make that association? I have had 2 patients that had the vaccinations, got ulcerative colitis. I was shocked, like there's got to be an association. Well, they did do a big study in Britain and it wasn't. So, but my mind is.
So, and here's the last question over here. Would you change diet away from all those nutritious foods or take enzymes? Looks like it was a rather or question. Would you change diet away from all those nutritious foods or take enzymes?
Oh, so you could eat unhealthy and just take enzymes. Is that eat a high-fat diet, take the enzymes, you're good to go? No, you should eat nutritiously. It's a separate thing. If you need the enzymes to digest the food, then you need the enzymes, but you should still eat healthy. It's not going to get you away from eating healthy, unfortunately. Yes.
Got it. And I'll give them like a couple more minutes to ask any more questions. It looks like that's it for all the open questions here. Any other last questions from the? Okay. Well, I think that's it from us.
Okay. Thank you. My pleasure. Thank you.